Okay, so I'm just going to spend a few minutes talking about molar pregnancy, both complete and partial molar pregnancy. Before I do that, I want to sort of step back and try to take a look at a broader category under which molar pregnancy falls under, and largely all of these pathologies are going to involve the placenta. So there are a group of four of them, and they're called gestational trophoblastic disease. And typically, there are four different types of pathology that are most commonly associated with this broader spectrum of pathology. And so the first is molar pregnancy, and I'll go through what the differences are between complete and partial. The second is invasive mole, which I won't be covering, choriocarcinoma, and then trophoblastic tumors. Within this category, just in terms of thinking about what's common and what isn't, molar pregnancy is about 80% of cases of all the GTDs overall. So it's the most common. And then within the different types of molar pregnancy, as I mentioned, there is both complete and then there's partial. And then within these two, complete represents 90% of the cases of molar pregnancy, and partial is a smaller percentage, just the 10% left over within this category. Next, in terms of thinking about epidemiology, the incidence of molar pregnancy within white Americans is thought to be about 1 in 1,000. And this number changes dramatically when we look at different geographical regions. So for instance, if we look at Asia and we look at South America and we compare these numbers to what we see in Europe, we're going to see that there are much higher rates in Asia. And this is particularly true in Japan. Then in terms of risk factors are the two biggest risk factors for this type of pathology is thought to be extreme ages. So either patients who are under the age of 20 years old or patients that are above the age of 35 years old. And then also just if they'd had a history of the same problem before, if they had a history of GTD, you're going to keep an eye on radar for them because they're more likely to have a recurrence of it as well. So the risk is about 1% in women who have had a prior molar pregnancy in the past. And in fact, this number can actually jump up to almost 30% for women that have had two different molar pregnancies before. There are a bunch of other minor risk factors as well, including the use of oral contraceptives, which has a loose link to higher molar pregnancies. Not enough beta carotene in your diet is actually thought to also increase molar pregnancies. And then, as we've seen in many other types of pathologies, tobacco use, such as cigarette use, can increase the chance of having a molar pregnancy as well. Okay, but what is complete molar pregnancy, or what is molar pregnancy anyway? And in order to answer that question, let's take a step back and remember that it's part of a broader spectrum of pathologies, again, that are called GTD. And what GTD tells us, again, that's gestational trophoblastic disease, is that there is some unusual proliferation of placental tissue. So there's too much placental tissue. Why does that happen? So they're a little bit different between complete and incomplete molar pregnancies. So normally in a normal pregnancy, it involves a normal egg and a normal sperm. And in this normal egg, we see this dark dot over here is representative of a nucleus. Okay, this is supposed to be the nucleus, and this is a happy, healthy egg. However, complete molar pregnancies can be caused when there is an egg without a nucleus. So this egg is devoid of a nucleus, and it's ultimately going to be fertilized by a normal sperm. So the sperm gets inside, and again, there's no nucleus in the egg. So when this forms, not quite a zygote, but when it forms, when the sperm enters the egg, we get a 23X picture. The sperm itself will actually duplicate inside of this egg, and now we will have a 46XX. We'll have a 46XX cell. The issue is this is all paternal tissue. Only paternal tissue exists here, and when it replicates and becomes 46XX and 46XX, again, everything that we're seeing here is strictly paternal because the maternal egg didn't actually have any genetic information in it. So now let's jump ahead and sort of think about, well, what actually makes the placenta abnormal within complete molar pregnancy? And what we have is trophoblastic proliferation. So trophoblastic proliferation again just means that the placenta is too prolific. And in terms of what part of the placenta is producing too much, it's the syncytiotrophoblasts here. And the syncytiotrophoblasts are really that outer layer of tissue that really connect more with the uterine with the uterine wall itself. So, what does that mean for what the patient sort of experiences? And to consider that, we really need to think about HCG. So HCG is produced by the syncytiotrophoblasts, and they're dramatically increased in complete molar pregnancy. So this is actually very helpful in terms of lab studies, and I'll get to that in a minute. But in terms of what we could expect the patient to sort of feel, we need to remember that there are two different sort of subtypes of HCG. There's alpha and there's beta, and so beta is very specific for the syncytiotrophoblasts. However, this alpha subunit is in many different things, and so your body might get confused. If it sees this alpha subunit, which is also part of LH, it's also part of FSH, and it's also a part of TSH. Your body may be confused and sort of think that you're secreting extra LH or secreting extra FSH, and that would lead to something called deconluteal cysts. Or it might also think, if it's the case of TSH, that it may lead to hyperthyroidism. And there are many symptoms of hyperthyroidism that we might expect the patient to feel. Okay, next, in terms of thinking about history and physical exam, this is a pretty good segue because we just talked a little bit about the hyperthyroidism. But before we even get to that, the biggest sort of symptom or clue in will be vaginal bleeding. That's heavy vaginal bleeding during what's perceived to be early pregnancy. So it's going to be irregular, it's going to be heavy, and ultimately this could actually lead to anemia, and that's certainly not necessarily part of your history taking, although it could be, but will come up potentially in the physical exam and laboratory studies. Next, going along with laboratory studies, one thing we'll see again is that very high increased level in HCG. And with that will come a variety of different symptoms. So, for instance, we might see some photophobia, we might see some changes in mood, either some increased agitation or irritation, potentially some increased signs of worrying and anxiety. We might expect the patient to feel dizzy. And then in terms of thinking more about what we would expect a fetus to sort of sound like at this point, there is no fetus in this case, and so we won't really hear any fetal heart sounds. Next, we'll sort of, when we continue to sort of examine the abdomen, we might sort of expect to see a uterine size that's greater than you'd expect it to be for the perceived date. Finally, we might be able to palpate some lutein cysts that I mentioned earlier due to that increased level of the alpha subunit. We might have some bolstered FSH and LH that could lead to some lutein cysts. And then in terms of thinking about diagnosis, we mentioned that earlier with the increased level of HCG. Ultimately, though, we're going to do an ultrasound, and the stereotypical thing to sort of see is that snowstorm appearance on the ultrasound. Instead of seeing a fetus, you'll see a sort of snowstorm appearance instead. In terms of thinking about treatment, ultimately you're going to need to do a D&C. Before that, though, it's very important that you get a baseline HCG because you're going to want to compare the HCG before and after. Other things you're going to do is sort of look at the CBC. This might be helpful in terms of assessing for anemia, and along with that, coag studies also to assess any risk factors for anemia. RH is important here. So, for instance, if the mother is RH negative, you would actually consider giving them RhoGAM even if there isn't really truly a fetus present. So that's another thing you're going to consider doing. And then also type in screen for blood because there's a high potential for bleeding for patients like this. And so after the D&C, going along with the idea of bleeding, one thing you might want to do afterwards is give the patient Pitocin. Again, and that's largely done to contract the uterus, to reduce the amount of blood flow there, to reduce the perfusion there, and ultimately, hopefully, reduce some of the possible bleeding that could occur afterwards. Thinking about things in terms of follow-up, one thing that's very important for patients that have been found to recently have a molar pregnancy is you want to encourage them to prevent pregnancy immediately afterwards. And this sort of allows us to really assess for if the HCG level has truly gone down consistently. So first, after follow-up, you sort of tell the patient not to get pregnant until we're certain that this complete mole has been completely eradicated. We're going to do that. And we're going to do that by testing for HCG levels weekly. And we're going to do that until we have negative HCG levels or negative increased HCG levels returning to sort of baseline state for 3 consecutive weeks. And then we're going to continue to follow that patient for months until we're confident, typically this is about 6 months, until we're confident that the HCG levels are truly down, this molar pregnancy is truly passed, and at that point, if the patient so desires and wants to get pregnant, that's something that could be more comfortably encouraged for them. Okay, so now let's really quickly talk about partial mole as well. So again, in complete mole, we did not have a normal egg. That egg lacked a nucleus. In this case, though, we will have a nucleus. We will have a normal egg with a partial mole. However, most of the time, this is formed when 2 different sperm come in to join in with the same egg, and we essentially have 2 sperm, 1 normal egg that gives us a triploidy, a 69XXY, and there are variations of this that can exist, but the 69XXY is by far the most common type. Again, showing with the external paternal genetic information, this will get passed down to 69XXY, 69XXY, and so forth. So we talked a little bit about the placental abnormality that came with the complete mole. Well, what about the partial mole? In this case, we're going to have both swollen and normal looking villi within the placenta. So here, instead of the syncytiotrophoblast being with proliferation, we're going to have cytotrophoblast proliferation instead. So what that really means is that the inner layer of the trophoblast is going to be proliferating more. And syncytiotrophoblast, instead, that was more of the outer layer. Here, with cytotrophoblast, it's the inner layer. And that's a difference, because in syncytiotrophoblast, we had this dramatic increase in HCG. HCG would go sky high, and in this sort of situation where we have the cytotrophoblast proliferating instead, they're not quite as responsible for making HCG. So sure, it can be mildly elevated, but it won't be dramatically elevated the same way that it was under complete mole. And just for a frame of reference, in complete mole, when I say HCG levels are high, they can be in the order of over 100,000. And this is not the case with partial mole, where you might see normal or slightly elevated HCG. What does this mean in terms of the fetus? So again, with complete mole, we didn't really have a fetus. Here, we do actually have a fetus, but it's typically spontaneously aborted within the late first trimester, or either then or in the early second trimester of pregnancy. In addition, when we sort of look at the fetus itself, we're going to see that there are multiple different deficits and defects within the fetus. So, for example, we might expect the fetus to have hydrocephalus. We might expect the fetus to have syndactyly. We might expect them to have some growth restriction. So these are all things that we might expect to see in utero for partial moles. In terms of treatment, it's actually quite similar to what we would expect to treat with a complete mole. A DNC is thought to be the best treatment, and it also actually offers the only true diagnosis. So if we wanted to really diagnose if this was actually a partial mole, just so we know about future risk factors for that patient, one thing we can do is assess that tissue and send it to pathology, and let them sort of analyze it and see if there was truly cytotrophoblastic proliferation within the intrauterine tissue. Finally, similar to what we wanted to do with a complete mole, it's important that we monitor HCG levels. Typically, for a partial mole, HCG levels should reach normalization in about 8 weeks. And this sort of contrasts with normal pregnancy, where we see these levels go back to normal in about a month. Or if we're comparing it to a complete mole, we would expect these numbers to remain elevated for much longer, up to about 14 weeks or so. And during this time, it's important that patients, again, refrain from becoming pregnant. So as their physician, you want to encourage them to use responsible contraception, just again, so we're sure that the partial mole has been totally eradicated before they try getting pregnant again.